This conference will now be recorded.
Hello, everybody, and welcome to the AnCan High Risk Recurrent and Advanced Prostate Cancer video chat for Monday, February 17, 2025. I'm Len Sierra, and I'll be moderating today with a little help from my fellow moderators, John, and I don't know if we have any others with us tonight. And of course, from our well-informed attendees here. We want to acknowledge and thank our sponsors, and they are Bayer, J&J, Myriad Genetics, Novartis, Telix, and Blue Earth Diagnostics. And as I've heard my other moderators say in this intro, we do not offer medical advice. Nothing we say should be construed as medical advice. All right. So we're going to start with Mark Valens.
Oh, I just see if anybody has any words of wisdom. I get my first Pluvicto infusion tomorrow, and I've heard you guys talk about make sure I go in there well hydrated and go ahead and take an anti-nausea pill before I go in there. Just any other words of wisdom?
Who here has taken Pluvicto? Well, okay.
Oh,
Al Latimer, haven't you undergone Pluvicto?
Oh, yes, I have. I was just about to raise my hand, and you beat me to it.
Okay.
I had Pluvicto starting in July of 2021 at UCLA. I had 6 doses with them, and then more recently I had four more doses in Miami, and their process was quite different. When I did it in UCLA, it was an infusion and it took an hour. And when I did it in Miami, it was a shot and it went in 30 seconds. But then you had to sit there and wait for an hour or so that they could test you with a Geiger counter to see if the radioactivity had decreased enough for you to leave. The information about the anti-nausea, that's good. Hydration, that's good. It's been a while since I did it. I'm trying to think of what else was good. Those are a couple of things off the top of my head. In terms of side effects, after a couple of treatments, dry mouth started to set in. I started using something called biopsy to offset it, which worked really well.
That's like something you gargle with?
No, it's a lozenge. You put it in your mouth and just let it disintegrate. Put it between your gum and your teeth, and it just it will disintegrate over 2-3 hours. It lasts a long time. They do have other things too. They have a mouthwash. They have a spray, which I use this from time to time also. And I say toothpaste. So I find those things all helpful with the dry mouth.
What was the name of that, Al?
Pardon?
What was the name of that?
Biotene.
Biotene. Can you see it on the screen?
Sort of. Okay, thanks.
You can pick it up in the drugstore, Mark.
Yeah, it's in the drug. It's all in the drugstore. It's over the counter.
Okay.
So Al, you've continuously taken these measures to prevent dry mouth. Does that mean that even after you're finished with Pluvicto, the dry mouth lingers?
It persisted for several months. It got worse before it got better, but I would say by 5 months or so afterwards, it was pretty much completely gone. I'm using it again now because I'm on something else that's reactivating the dry mouth. The Jevtana is reactivating the dry mouth, so I'm using these things again.
Oh, you're taking Jevtana now.
Yes.
Well, as long as we've got you on the spot here, why don't you just continue and give us your update?
Well,
Thank you.
are we finished with
Oh,
Pluvicto?
yeah, I'm sorry, Mark. Are you
I
okay?
I didn't hear any more coming. Oh, John, did you have something? No, I guess not.
So no, I did. I just wanted to let you know for maybe for a year from now or something like that. I heard a presentation for what will be a competitor to Pluvicto. It uses an antibody linker instead of a small molecule linker between the payload uh, and the PSMA, and it's going to have a longer half-life, and it's only going to need 2 treatments.
Uh-huh.
So we're hoping it'll be a little bit better tolerated. Seems to have less side effects so far.
Okay.
Mark, may I ask what your PSA is now?
I've never had any PSA, so it's under 0.2.
Oh, okay, but you've had you're positive for PSMA.
Yes.
So okay, so the decrease in your PSA really won't be much of a marker for you as to whether or not it's helping. I guess it's going to be the scans.
My PSA was 1 when I had 5+4, um, cancer. So PSA is not a good marker for me at all.
But you've had a PSMA PET and it's positive.
Yes, it showed I've got all kinds of mets up and down my spine.
Okay, so after your 6 sessions, they'll do another PSA and see how, or another scan and see how you're doing.
We're going to do
In
them
my,
after every second cycle. We're going to do another PSMA.
okay, every second cycle. So in my case, I had a lot of lymph node mets at the time, and they all completely disappeared with the 6 cycles.
That'd be
However,
great.
however, 6 weeks later, my PSA started going up again, so I did not have much of a holiday with it.
Okay.
So everybody's different. It reacts everybody reacts different to it. Everybody's cancer reacts differently to it. So good luck.
Thanks.
Kind of a good example of how unlinked PSA and PSMA can be. So we shouldn't be fooled.
Yeah.
Question.
Mark, did they tell you they might use ctDNA as a screen for how well the Pluvicto is working?
My doctors haven't mentioned it. I did read something online about it.
Ask them about it. Maybe they can
Okay.
do that instead of a scan, or in addition to a scan. Steve L., you have your hand raised.
Yes, just asking what kind of anti-nausea med is recommended prior to the treatment?
Um, Campa. Oh, I can't remember the name of it.
Is it a prescription?
Yes,
Okay.
there's 2 of them that they prescribed when I went through this. Had nausea before, and one of them was really bad constipation. So I'm not taking that one, but this other one is not near as bad. The constipation.
A couple other things they're probably going to tell you is when you pee, how you're supposed to pee. You got to sit down on the toilet. You got to flush it 2 times. He probably went through all that with you.
Oh yeah, they tell me 3 times I have to flush it.
Oh, 3 times now. Okay.
Yeah. Okay, thanks guys.
All right, Mark, good luck. And, I was wondering, Since they give these white blood cell stimulators with chemo, and Pluvicto causes just as much neutropenia as far as I can see, I wonder if they ever use the white blood cell stimulators for Pluvicto. Anybody know the answer to that one?
You're talking about like Neulasta?
Yeah, yeah.
I can't see why not, although I don't think we've had an AnCan guy getting Neulasta while he was on Pluvicto.
They did not give me Neulasta.
Do you recall how low your white blood cell count became?
No, but if you really want to know, I can look it up. My white blood count now is high normal because I'm on Neulasta now.
Okay.
But back then, I don't know. It was low normal. I don't think it got very low.
Okay.
Len, I have a question.
Go ahead, Rick.
Is the white that Neulasta, is that the same as the growth factor? What I forget what the abbreviations are, the GNF or the GFR?
Yeah, yes. Granulocyte macrophage colony stimulating factor, GMCSF.
Right. That's the same thing as Neulasta, right?
I believe that's Neulasta. Yes. If it isn't, then it's there's another trade name for the one I just mentioned. That
Okay.
they're very similar.
Because I was just reading some research and they referred to the GF whatever it is, and I in my mind thought that's Neulasta. I wasn't sure, so I needed to check.
Yeah, there are a few of them out there.
Right, but it's one of those things that supports your white. It support. I mean, the bottom line is it's there to support your white cells, correct?
That is correct.
Yeah.
It doesn't do anything for your lymphocytes, but it stimulates the neutrophils, the ones that fight infection. That
Okay.
portion of it.
Yeah. As long as that's what it does, okay. Hello,
That's why
Dr.
it's called
John.
NEU. That's why it's called NEU, N-E-U, for neutrophils.
Ah, okay. Thank you. That'll help me remember.
Okay. Kang, you are next up, and would you like to bring us up to date?
Yes. My PSA become detectable at the end of 2023, which is after 3 years of undetectable with the abiraterone and Antigard, and also radiation of SBRT. When it first passed the threshold of detectableness, it was 0.03. Was end of 2023. Now the current one is 6.6, which is about a few weeks ago. I've done 4 PSMA along the way, also one FDG scan, and nothing was showing up on the scan, but the PSA has been rising. So the 19th, actually the day after tomorrow, I'll be seeing the oncologist again. I'm sure there will be a lot work done. So I believe the PSA probably will be maybe around 7 or 8. Yeah, I don't know why the imaging doesn't show anything, but the PSA is going up.
Kang, neither of the PET scans showed anything? FDG or PSMA?
One FDG didn't show anything. That was done at the end of December of last year, which is about less than 2 months ago. And the current PSMA was actually in January. Actually, no, on the 10th of February, which is about 10 days ago. Nothing was showing.
Wow.
Um,
Maybe this would be a good case for ctDNA or,
Yeah.
that's what Rick was suggesting.
how are you going to monitor this?
Yeah, the problem is I'm still, and of course, in all the stuff we heard, everybody's using ctDNA in the lab. I'm still not convinced, but I do have some news because I stopped by Natera, and this is very important for our guys. Natera told me, and I think I have his card in I literally haven't unpacked, haven't done anything, but Natera will pay for a ctDNA test. If your insurance refuses it, they will not bill you for prostate cancer. Because I went up to them and I said, what do we do with guys who need a ctDNA test? And well, we're all approved. And I said, well, you're not. Because I said, yes, for breast cancer, but you're off label still for prostate cancer. It's okay. We will pick it up. So I would say insist that your doc orders a Natera, the test is Signatera, the Natera ctDNA, and and then we'll submit it, and if the insurance doesn't pay for it, we will take it up with Natera, because he absolutely promised me. The guy at the who was, I don't know who he was, director of sales or whatever it was, and we can try and confirm that as well with Natera, or you can try and confirm it with Natera. Reach out to Natera. But this guy told me absolutely point blank, yes, we will pay. And I said, and we won't overbill, meaning they won't come back to you on anything the insurance doesn't pay. And I said, well, what if the insurance doesn't pay at all? He said, no, we won't bill for prostate cancer right now.
So this will be brand new news, even for the clinics, physicians.
Well, they need to reach out to, they need to do what I did, which is go talk to the people at Natera and hear it from them. But I agree with you, because I was surprised.
How do you spell Natera?
Natera.
Natera. Okay.
They have a nice commercially available ctDNA product for ER-positive breast cancer. So they should know what they're doing.
The issue is that with the breast cancer, they are sensitizing it with a biopsy. And I don't know how they would approach doing this for prostate cancer, but the guy told me, yes, they'll do it for prostate cancer. So they may need either when was the last time you had either a tumor or your prostate biopsied?
The funny thing is, I actually did a biopsy back in the States. That was the second. That was 2021, right before the SBRT. For some reason, my doctor never did a somatic test.
Right.
He did a blood germline test, but there's no somatic test. So, but that was a few years ago. I don't know whether it's still good or not.
No, it should still be good in one sense, The problem is it's not going to be where you are today, and we don't have anything to biopsy because we can't find anything. I don't know whether they can extract ctDNA, they can extract DNA from your blood and try and sensitize like that, but which, you know, it really means you're going to have to get into the weeds a little bit with Natera. And I'll look for what I've got tomorrow. When you know, I'll look and I'll send it to you and Len. But I definitely recommend you ask your doc, the guy what's his name at your Chinese buddy at
Tall
Sinai.
from Sinai.
Yeah, to reach out directly and ask Natera how they're dealing, because the mods here, we all feel the ctDNA test is very relevant to our guys. But the problem is it's not available. And now Natera says, well, yes, it is available. We'll do it for your prostate guys. And I said, well, this is amazing. Thank you.
A question: for ctDNA to work, you need a tumor. You need actually biopsy tumor to do it? Or?
Well, you know, there are people who do it in a different way. The way that I don't want to say traditionally because that sounds like it's been around forever. The way that the Signatera test works, they get either it's approved for colorectal and breast, I think, right now. And what they do is they get a tumor that they analyze. They get a piece of tumor tissue that they analyze, and then they sensitize their test by what they found in the tissue. Does that make sense to everybody? Now, I don't know what happens if they have no tissue. I don't know if they can sensitize it without having a tissue sample, or if they're willing to do it based on a 5-year-old biopsy. I just don't know. But somebody from maybe you and Len can call Natera together, or maybe your doc will call Natera and get more information. But they're willing to do it if we can tick the boxes.
I'd like to get the opinion of the folks here. I suggested to Kang that he ask either one or both of his medical oncologists if it's worth considering doing a different metabolic scan. Like, PSMA is only good if the cell's producing PSMA. A metabolic scan, as we know, should be picked up by any cancer cell that's metabolizing, that's growing, such as Axumin, which is reasonably sensitive. Or I don't even know. I guess the only place still doing C11 choline is at Mayo. But I don't know. What do you folks think about that? Just to see if they can find something.
I thought your suggestion, because we've been writing between ourselves on this situation. I think Len's suggestion to do an Axumin at this point in time is really good. I mean, we're scrambling around trying to find out. There's something there. We can't seem to find out what it is. I think an Axumin is very good, and I also think we need a ctDNA test of some type or the other.
Yeah.
The only one we're familiar with is the Signatera.
Right. The odd thing about Kang's case is that he did have a positive PSMA scan when he was in China in 2020. All of a sudden, the PSMA is gone.
Right.
And maybe the FDG is not picking up anything because his cancer is not growing fast enough, which is one of the reasons why FDG is not often used in prostate cancer.
Mhm.
But anyway, Larry Schuler, you have your hand up.
I'm getting all my cancer care through the VA and through one private provider I'm paying for myself to get my prescription. And so I've been interested in circulating tumor cell analysis for quite a while. I'm post prostatectomy, and my PSA is down 0.0.
Okay, Larry, can we talk about Kang, and we'll come to you if you need time. What is your question with respect to Kang and ctDNA?
Well, I sent you in the chat. How do I
Yeah,
contact Natera, and what do I ask?
I can't concentrate on the chat, man. I've told you guys all before. What's your question right now for us?
What's the best way for me to contact Natera?
I don't, as I told you, I just said to you, I think I have a card. I don't know. I just got back this second. You can go to natera.com or signatera.com, and I'm sure they've got they've got information right on there. I know they do because I've looked at that. And Len and I have signed up. Len, did you go to the? I didn't make it, but I have it still to look at. Did you go to that the webinar they just did on breast?
No, I did not.
Okay.
Somehow, maybe I wasn't on my calendar. I don't even know that it came up. Anyway, Steve L. put a contact number for Natera.
Yeah, that's great. Good job,
chat.
Steve. Good job. Follow up right with that number, Larry.
Oh, thank you.
And the issue with the VA pay for it, I don't know. Would they give it to you as a vet? They might do. There's
if it's off-label,
no. Sorry, what do you say? They won't pay. All right, let's come back to you and the VA afterwards.
If it's off-label, no.
Okay, well then you'd have to work it out with Natera because essentially you have no insurance. So would they do it for you as an uninsured person? I honestly don't know. You'd have to ask them directly.
Well,
but the other thing is we don't. I mean, Larry Schuler may be a good case, but we don't want everybody running out and saying, "Oh, I got to get a ctDNA test." This is a test really for very special situations. For somebody like Kang, where we can't figure out what's going on, we want to know if there's cancer cells flying around his body. That's one situation. Another situation where it could be good with Mark Valens, because we can tell, we want to know early on, is the Pluvicto working? So a ctDNA test, if done at the beginning of the treatment and then after 2 or 3 treatments, will give us a good idea if the ctDNA treatment it is. But this is not a test for everybody to go out and say, "Oh, I need to get a ctDNA test."
Okay. We are going to go to Wes in San Diego.
Thanks much, guys. So I'm making progress. I'm learning their jargon. My question is proton versus X-rays. I'm coming up, likely to have 6 weeks. Got to meet with a few people, talk about hormones, but that should start here in a couple of months. I am told, let me pose, I'm told that they're essentially the same efficacy for killing cancer, roughly the same in terms of side effects, because X-rays have improved over the last few years. How say you?
That's my understanding as well. Somebody else have a different opinion? As a matter of fact, I think they just recently concluded trials doing head-to-head comparisons.
Right, there's a Harvard study they cite that they think is pretty good. proton people will sell what they have just like any vendor.
Yeah.
But
I think
Anyone
if it
else?
was me, I'd go with X-rays.
Yeah.
well, I moved
Somebody,
over. Go ahead, Rick.
someone in the plenary, guys, I don't know if you remember, Dr. John, but in the plenary, somebody actually asked about proton versus photon. And I can't remember which panel it was. And they gave the exact same answer we always give. This was in the plenary session last Thursday. There's no difference. It really doesn't make a difference. None of the studies have shown that there's a difference. Now, there are certain people who attend AnCan, watch AnCan, insist otherwise. But our party line here is it makes no difference, and exactly what that study says. You know, the guys who proselytize for proton have some wares to sell.
Okay, let's call that close enough. And I lied. I have a second question. I took Rick's advice. I'm over at UCSD. We talked the other time about a PET scan that showed a hot spot on my left rib. They did an X-ray, which was non-conclusive. Is there something else that I could do to exclude that?
Wes, I think that's coming from you.
Yes, I don't know what that was, man, but we thought you were blowing us up.
We
Can
heard
you-
it. We heard you get as far as to tell us you've made a connection at UCSD.
Okay, let me.
After that, I think we lost whatever you said.
Can you hear me?
Yes.
Yes.
Oh, I can't hear you. Okay. Why don't you call
Because
someone else and I will try to resolve my hearing
yeah,
issues.
yeah, we stick a message because he selected his headphones. That's why he can't hear us. He
All right,
needs
so
to-
we're
he
coming
needs-
back to Wes.
Yeah, we'll have to come back to Wes when he just needs to. Can you hear us now, Wes? Can you hear us? Evidently not.
Not a blink.
Well,
All right, let
let's
me send him. I'll send him a message.
okay. Meanwhile, we will go to Steve Lynette. Go ahead, Steve. Is Steve with us?
He's muted for one thing.
Steve L. Steve
Steve
L.
L, you're muted.
Unmute. Unmute, my man.
Yes, thank you. Yeah, just a little bit of an update. I had a question earlier about my dexamethasone dose. I had changed from prednisone to dexamethasone, and finally got confirmed from my doctor that that my thought was correct. The dose should be 0.5 once a day. And not twice a day. And also, I'm continuing to have some lung and oxygen issues following the Provenge-induced pulmonary embolism I had, and I finally got around to starting some pulmonary rehab in the 1st of March. So I'm hoping that'll help. I don't know what to expect with pulmonary rehab. If anyone has any experience, I'd appreciate it. And then I'm also meeting with a radiation oncologist the first week in May, and for debulking a tumor and some treatments of some nodes Has anybody heard of using brachytherapy for that? It seems like it might be an option, which surprises me.
Mhm.
Yeah, definitely an option. I think, Rick, you had brachytherapy, didn't you?
Yeah, I mean, when a lot of the time when they debulk, they do not um, focus on the pelvic nodes. Now, I'm not sure why, and I think if it was me, I'd ask for it, especially if you you're oligometastatic, particularly if you're oligometastatic. You know, it's sort of an issue around do no harm, but I feel like it could make some sense, but that's got to be a discussion between you and your doc, because the protocols that I believe supported the debulking did not go across the pelvic girdle, although some ROs do it. There's no reason why you couldn't debulk with SBRT, with brachy, or SBRT or IMRT. If it were me, I'd ask for SBRT,
Okay.
because that's the cleanest and simplest. You can do it with brachy in either one session, or if it's high dose, one session or 2 sessions. They're probably talking about high dose for you, which would either be 1 session or 2 sessions. But the SBRT can be equally as effective, and it's a lot more patient friendly.
Okay.
Steve, I think you have proven lymph node positivity, right? And
Yes, although,
brachytherapy is not going to touch that.
okay. And in fact, it has cleared by the hormone treatment. I'm not showing any Mets now, um, but I am starting to show some questionable activity in the seminal vesicle, one side.
Yeah.
If it were me, I would be saying I'd like SBRT and radiation across my pelvic girdle with IMRT. That's what I'd be asking for. I mean, that's similar to what I got, except I got brachy way back in the day. I'd ask for SBRT now, and I would advocate for that for myself, notwithstanding. And I, I feel like it makes a difference, but you know, you've got to talk to your RO, and you'll finish up doing what they're willing to do. But I would have them tell you why they won't do it.
Yeah. Sounds good. Thank you.
All right, Steve, thank you. Let's see. Where's Wes? Is he back with us? Wes, can you hear us?
Yes, yeah, my Bluetooth works just as well as I do. Anyhow, question. I
Very
figured
good.
I'm speaking to a crowd that should find that either
I
depressing.
find it. I find it amusing. I do. I do. It appeals to my sense of humor.
Well, it's a little bit macabre, but anyhow. So I have this hot spot from PET on a rib. Makes no sense other than I had a Heimlich. Told you guys that last week. My magic guy Liss was willing to do an X-ray. The X-ray was non-indicative, so I don't know that there's anything else I can do to do a rule out of that as a potential cancer site now. I don't really like the idea of waiting 18 months or 2 years and going, oh yeah, your PSA is still high. We don't know why. Let's gamble on that. I'd rather solve as many issues up front as I can. I don't understand what a bone scan is, or if there's another option for that rib.
Just to remind us, what did it show up on?
Yeah,
It showed up on the PSMA as suspicious. Was that it?
It showed up on the PSMA as a hot spot, and I can be more precise. But I had one in my neck with osteoarthritis that you guys said, well, that's sort of curious, because that's not common. And the rib, when I was at the prostate summit conference, somebody acknowledged that they do see ribs occasionally as false positives, which is annoying. So my MD is willing to ignore it as a potential false positive. He was willing to do an X-ray. Okay. Just asking, is there any other test that you guys know about? In the old days, they used bone scans. They claim, I believe, the PSMA has replaced those. I don't know if that's true.
Yeah, that is true. Some radiation oncologists think it's a waste of time to do a traditional bone scan, which means either the technetium bone scan and even the F-18 PET bone scan.
Okay.
I don't even know if it's still approved by insurance for reimbursement for the latter.
So, I think there's a couple of things that you could do, and we'll see what John and Len think. But first of all, just tell us. I mean, we were very suspicious about what was going on up on your top of your cervical spine and your scapular area. Have you asked Liz again about that?
I have not seen him. I will see the radiation guy early March, and the oncology team person at UCSD later in March, Randall Siebert, shortly. So no, I have not asked. I've not done any follow-up after the X-ray results came out.
Okay, I think you really have to, and you have to do it before you start getting too involved with your radiation, because it can change your course of treatment. We have to establish and totally rule out. It sounds suspicious to us, but what do we know? But it does sound really suspicious. You need a second opinion. If it were me, I would be getting a second opinion on what's going up around your neck area. I think that's really important. Because if it turns out that those areas are in fact cancer, then it may change your decision making right now. How many spots were there that look weird around your top of your thoracic or cervical spine?
Just a sec. Let me. I'm pulling up the document now.
I think it was one.
Just one?
I think so.
Well, I'll read to you what it says. So, head and neck, no focal lymph node uptake or lymphopathology, physiological uptake in the lacrimal and salivary glands. Okay.
Well, look.
Okay. Musculoskeletal. Hang tight. In addition to physiologic uptake seen in the bone marrow, focal uptake in right C3 facet joint associated with destructive change. SUV max is a 6. Then
it's hard, Wes. It's hard for us to absorb this like this.
I bet.
We can't just listen to what you're saying. We need, maybe one of us has to work with you to look at it and to see it. But if it's one single spot, which my notes say, and Dr. John's notes say, then that might be another spot equally as important to focus in on. I would say an FDG PET, if you haven't done one, is something you could do, and an Axiomin, just like we said to Kang. I would start with an FDG PET and see if either of these spots show up on an FDG PET scan.
I was interested to hear you say it said a lesion of the C-spine associated with destructive change. That almost makes it seem like there was some damage to C3.
Right. So I had X-rays that identified various different osteoarthritis in essentially all my cervical joints. Cervical parts, may not be precise. And Rick, I was going to follow up. I'm trying to figure out how to get a second opinion at Mount Hope or somebody so that they actually see my PET scan along with these x-rays of osteoarthritis x-rays so they can do compare and contrast. At least that's what I would do. I'm not sure anyone has looked at both of them. And like for the rib, it's just floating out in space. They're claiming, in any case, I'll do a second opinion, but I just wanted the jargon. I don't know what FTG infers or means.
Dr. Jeff, you had your hand up?
Hold on a minute. Hold on a minute, Dr. Jeff. Len, do you want to explain what to Wes what an FTG is and an Axiom scan?
Sure. Well, as I already explained that before, those are both metabolic scans. FDG is fluorodeoxyglucose. There's a radioactive glucose, and it'll be picked up by cells that are metabolizing, growing. Problem is that it's glucose, so all of the cells, of course, uptake glucose, and in prostate cancer, you have to have a rapidly growing tumor to, let's say, distinguish it from the normal glucose uptake of all your other cells. So that's one possibility. The Axiom scan, also a metabolic scan, they use a synthetic amino acid called fluciclovine that is used by the cell as an amino acid that's radio labeled. And so if a cell is growing, it'll pick that up. And that's before PSMA PET. Axiom was, for a short time, the best scan that was available. So it's a reasonably sensitive scan.
Okay. Well, you guys can move on. I appreciate Larry's comments in the chat and my follow-up. And I do tend to have somebody else weigh in on what they think about my condition before I go down a singular path that may not be sufficient.
But Jeff, before we move on.
So there are two other options. One is, have you discussed getting a high-resolution ultrasound of your rib? And the second is, if it's accessible, you could have a biopsy and see exactly what it is on your rib.
Okay.
The second is not really an option with respect, Dr. Jeff. I know that for prostate cancer, they rarely will biopsy a rib. In fact, I've never heard of it. They usually turn it down because it's too fragile, and and too small, so that they almost never. Guys, have you ever heard of a rib being biopsied? I've heard it turned down often, but I've never actually heard somebody actually biopsying a rib.
Just one more thing I wanted to mention, Wes, is you said something like you don't want to wait 18 months or more to see what happens with that rib. I mean, why would you have to wait? I don't understand why you feel you have to wait that long. Let's say if you're getting your PSA checked every 3 months or whatever it is, if you see the PSA start to rise, then they'll do another scan and they'll compare the new scan, that particular lesion on that rib, whatever it is, to the previous scan. If it's growing, then you know it's cancer. If it's not, probably isn't.
Right. So I don't know the timing of, after I go on hormones, supposedly nothing should grow. So I don't know the sequence of that. That's why I just simply said they were going to put me on hormones for 18 months, then claim victory and watch. And this whole recurrent thing has me forewarned.
I was just going to mention, I had my collarbone, the clavicle biopsy for prostate cancer. Actually was done by NIH when they were still developing their PSMA scan technique, and it was difficult to do, but they did it. They said there was nothing there, and it shows up as a lesion when I had subsequent PSMA scans, but it doesn't absorb much of the active radioisotope. And they always say, yeah, this is something that's sclerotic, and it never really did much, and not to worry about it. And so, the advice given that just look to see, does it grow, does it change, is probably as best as can be done for that kind of a lesion.
I definitely appreciate the conversation and um, Len. So, in an ideal world, I start hormones for a month or two. I have 6 weeks of radiation therapy on my pelvis and my vesicular, so forth. And then, at what point would a subsequent PET scan, be indicated if the PSA is not 0 or whatever?
Well, typically they wait for your PSA to get to 0.2, although lately they're even doing it at 0.1. But, if your PSA is undetectable for 12 months, 18 months, obviously you have nothing to worry about. There's nothing
That's
going
good.
on.
Yeah.
Yeah.
What we don't know, Wes's PSA is now over 6. So what we don't know is what will happen to that once he gets started with ADT.
Right. But let's say it goes down to undetectable. Is that a bad thing? I don't think he has to worry about the rib if his PSA is undetectable.
Yeah.
Well, my point is my likely date of death is 12 years out, all things being equal, cardiovascular disease based on my lineage. So I just don't want to stay on this train, even though I really enjoy your guys' company. If I can say goodbye to you and this topic for a good chunk of the rest of my life by doing some due diligence up front. That's really my motivation.
Yeah. Jack, you have a comment?
There's one more alternative that hasn't been mentioned. There are some oncologists who, when there's a questionable metastatic lesion in the rib area or elsewhere they're not too sure of, and they can't do a biopsy, one of the things that can be done is you can go on ADT for 3 to 6 months and check it out again and see if it's still present. And there are some people who use that diagnostically as a way of determining whether you have cancer in the rib or wherever it is that's questionable. And if it disappears, it's almost diagnostic that you do and did have metastatic disease. If it doesn't, stays the same, that's good news. It's probably something else, an injury, a sclerotic change or whatever.
Okay.
All right.
Len?
Oh, go ahead, John.
Essentially,
If it's okay with you, I'd like to get a word in edgewise now that we're mentioning scans. I heard something surprising at ASCO a few days ago. Last week I told you guys that I thought the inter-rater reliability for MRI scans was probably pretty good, other than PIRAD scores, and it wasn't so good for PSMA, meaning would different raters call it the same. But I heard a radiologist a couple of days ago say exactly the opposite. He said that 2 radiologists can really read an MRI kind of differently, and he thought that PET scans were now even better than that in terms of second opinions, reliability from two. So I was surprised to hear that, and it changes what I said last week a little bit.
Okay. Thank you for that. Next in line is Michael Chandler.
Aloha from Maui, sending warm aloha. Everybody, just an update. I'm 13 days ago went on ADT, and symptoms are pretty minimal. And I'm flying to UC San Diego Health a week from today for a mapping appointment. The prostate cancer spread to my T10. My PSA level was 0.67. I had my prostate removed 3 years ago, all my treatment at UCSD. And then the following Monday, I'm signed up for 3 high dosage of radiation on my T10. And the good news is it didn't show up in my pelvic floor or pelvic region, but just apprehensive. And my in-house manager, my wife, Cheryl, has shown me a lot of information on how I need to eliminate alcohol every evening, which I've done the last couple days, and that's going well. And but alcohol's not helping my 2 oral chemotherapies I'm on. It diminishes their effect, and so just a lot to take in. And thank you for including me.
What are the oral chemotherapies, Michael?
That threw me off too.
That's how I do it. Oh,
okay, that's not chemo. We call that a ARPI, androgen receptor, or RC, androgen receptor signal inhibitor.
Okay.
But anyway, it's a hormonal drug. It's not considered chemotherapy.
All right. Well, thank you for correcting me. And then Ruluxcolux.
Right.
And then a little bit of prednisone to offset those 2 drugs. And just surprised it migrated to a hot spot up on my T10. First showed up in a PSA PET scan, but radiologist Dr. Brent Rose said they have some false positives, so they statted me and followed it up with an MRI, which conclusively showed a hot spot that we're going to radiate.
Well, that's probably a good idea. Metastasis-directed therapy, they call that MDT. And if you have fewer than 4 metastases, it could shorten the time you need to be on hormonal therapy if it's successful. What about diet, exercise?
Yeah, I play tennis 5 days a week, and
Okay.
Dr. Rana McKay, medical oncologist, I've been under her care for 4 years. She's indicated a year of ADT therapy, and so I'm signed up.
You can look forward to saving a lot of money on deodorant now.
Thank you, Dr. John, and thank you to Rick and everybody for directing me to Center of Excellence, a teaching hospital, and as the gentleman who's seeking his care at UC San Diego Health, we both attended a prostate summit, a seminar on a Saturday for 8 hours, and I'm just blown away that my surgeon, my medical oncologist, and my doctor of radiology led the seminar, so I'm in the best hands. I'm very happy.
So a couple of things, Michael. Totally understand why you're calling them oral chemotherapy, because they are systemic treatments. But we make a slight distinction because both those drugs act on testosterone only. So in a sense, they're sort of precision, and always have been from the earliest times, in that we're really just addressing testosterone with those drugs, and to a certain degree estrogen, which is why you get some of the symptoms. But we're addressing very specific hormones And in a sense, they really are. It really is chemotherapy. We just have a different name for it in for prostate cancer and even for breast cancer, where they use similar drugs to control estrogen. We refer to them as hormonal agents as opposed to chemotherapy, but they're systemic in exactly the same way that a chemotherapy can be systemic and kills it. But although the chemotherapy will usually act directly on a cell, and what these are doing are something a little bit different. They're stopping the testosterone, which stops the cancer growing, and they're blocking pathways for the testosterone to get to the cancer. So, but it's, to think of them as chemo agents, yes, that's okay. Your comment about alcohol, and I wouldn't, God forbid, argue with Cheryl. I'm sure she's like absolutely right. Although I haven't actually seen those studies that advise, and some of you guys who have been on Abbey know. I mean, I don't think that alcohol has an impact on the androgen deprivation drugs, although again, it may do. I haven't seen that research. But I'll give you my own philosophy, which is anything in moderation is fine. If you have 3 or 4 drinks every night, that ain't good. If you have one drink 3 times a week or 4 times a week, that might be okay. People will argue, there's a lot of arguments around alcohol. People will argue you drink red wine, it's a great antioxidant, it helps. There are other people who argue, no, you can't have it for cancer at any time. I think I put something in the reminder a couple of weeks ago about that. So you can be more stressed out from not having, the not being able to drink at all. But this is how I feel about it. I don't live with your wife. So you have to figure out. But if it were me, I maybe have 2 or 3 pops a week or 4 pops a week. I mean, but just don't overdo it. Anybody else want to comment on alcohol?
Well, yeah, I would say that, it's a vasodilator, which means you're more likely to have hot flashes if you're on these hormonal medications and you have alcohol to drink. You'll probably see it. If you have a glass of wine, your hot flashes will probably get more intense. In general, what Rick said, yeah, everything in moderation.
Yeah, that's what I was going to say. Everything in moderation. Thank you. I'm doing well and in good hands, and just hoping that I get no more hot spots in the future here, and looking forward to shutting down my testosterone with these drugs. And reading one of the books, I'm just very lucky I could afford 2 weeks ago afford these 2 hormone drugs, and was surprised that UCSD Health, when they said, "Oh, this is for these two, it's $1,800," and luckily I can afford that. And I feel sorry for the people that can't, or the insurance won't help it. But I'm almost reaching my $2,000 deductible with Medicare, and but it's a better option than surgical castration to shut down the testosterone.
Yeah, I mean, you raise a very good point. I think that this $2,000 limit is helpful to a lot of people because it's a manageable amount on an annual basis. It isn't that long ago where we were dealing with people who were faced with that on a monthly basis. And that was really difficult, and we would scratch around and try and find them deals, and some of them were paying 700 a month and happy with it. And then certain other things happen. I'm sure there are guys on here who were paying an arm and a leg for a short period of time. It's really tough. But now, if you're on Medicare, if you have Medicare, you're limited to $2,000 a year, which is a heavy step in the right direction. Dr. Jeff, you have your hand up.
Yeah, so if somebody is taking abiraterone and drinking alcohol and their LFTs go up, how would you know which is the cause of the LFT elevation?
LFT?
Liver function test.
Liver function.
Liver function test. Okay. That's a very good point.
I'm going to be doing labs every 3 weeks to track that.
Yeah, but what Jeff is saying, and it's a very good point, is that your liver can get out of whack when you take abiraterone for sure, or even androgen deprivation therapy. I mean, in my case, my ALT and my AST, and I was just on Lupron. They were marginally high all the time as a result of being on the ADT, and Dr. Jeff's making the very good point. Well, if you drink alcohol, that could also push it up. But I think one answer to what Jeff is saying is if you do it in moderation, if you have 1 or 2 drinks a week, I mean, is that going to push your LFT? Is that going to affect your LFT? Jeff?
I'm not sure I'd want to have things introduced that could cause more confusion because alcohol can, for given individuals, affect their liver. And, do you really want to have this synergistic effect, negative effect? Because, if abiraterone really throws your LFTs out of whack, as it did mine, and I don't drink, at the beginning, they were considering switching me to a different medication off of the, now I didn't need to, but, you know, I would just be hesitant to combine 2 things that could raise your liver functions.
Less is better or none at all. And I don't want to take any more time. And thank you, gentlemen.
No, I mean, I just want to say to that last comment, I don't want to take any more time. These discussions are really helpful to a lot of guys. This isn't about you. This discussion about alcohol and abiraterone, there are a bunch of guys out there, and all the guys who listen on the recording who are very grateful to have this discussion. So think of it in that way, that all the people that we're helping who listen in, and now we'll get other people sending us notes and calling and say, well, what about this with the alcohol? Or can I have, what about if I have a beer rather than red wine? Or, but it's not just about you. It's your concern, but it affects a lot of guys, Michael.
Well, good stuff. I just want to stay around for a long time and continue to try to play tennis so I can live without alcohol. And it's real simple, no doubt.
So, safer than driving race cars, eh?
Oh, no, that's stupid. I was in my early 20s during my 4th Indy 500. A car failed. I hit the turn 3 wall and was in a coma for 12 days. And that was stupidity.
Okay.
All right. You never know the background of guys on this call.
Really? That's really true.
So, Rick, we have a serious problem now because I'm out of people to call on.
Oh, my gosh.
Len, I actually had my hand up, Len.
Oh, I'm sorry. Go ahead, Gary.
So, Rick, on that $2,000 Medicare drug limit, that's only if you have a Medicare drug plan. Is that right?
Right. Yes. I mean, if you don't have Part D,
right.
I don't believe you have any protection. So you must have a Part D, or you must be on an Advantage plan. You can't be paying more than 2,000 if you have Medicare coverage either through an Advantage plan or through a Part D plan.
Part D is in dog, right?
Yes.
Yeah. I don't have that, so I don't get the benefit. I just wanted to confirm that.
So how do you have Medigap?
No, I kept my insurance through my employer after I retired. So
Okay.
that is my secondary insurance.
So
But
I think that's
you've
considered.
never.
Isn't that considered Medicare Part D, employer sponsored, something like that?
Yes, I thought so.
Yeah.
what was
You
that?
do have it.
And what was that you said?
There's something called prescription drug plan through your employer. That's what I have, actually. I have Medicare Part D from my employer, employer insurance. Even after I retired, we kept the insurance. So it's probably the same thing you have. It's basically it's Medicare Part D. It's blessed by Medicare for certain private companies to provide drug coverage to people who are eligible for Medicare.
I'll check, but they told me I was out of luck.
They already told you were out of luck?
Yeah, I checked to see if I had any coverage on a couple of drugs where they changed the formulary. So these drugs went up from affordable to pretty unaffordable. And I called up the secondary and said, do I have anything with Medicare that can help cover this? And they said, no, you have to have Part D. And you don't have any Part D.
I mean, I'm a little puzzled because if your Medigap plan, your secondary insurance over Medicare, is Medicare is a Medicare approved plan, which it must be, then I would have thought that your drug plan would also be in the way that Lens is. What I would suggest,
It could be, Rick. It could be that the private drug plan coverage, they just changed their formulary and they're not covering a certain drug that Gary's taking, I guess.
Right. That's what happened.
Yeah.
Well, that could be, but he still should be covered to the extent of out-of-pocket costs.
Unknown caller.
Well, I'll try again.
Yeah.
What I would suggest you do is reach out to the folks at Triage Cancer and ask them, because they really are experts in this field. They understand it a lot better than we do.
Okay.
And when you start talking about you have this secondary situation, they're going to understand the ins and outs of those secondary policies better than we are. So I would go to triagecancer.com, and there's a telephone number on there, and they will advise you.
Okay.
Let us know, please, so we can learn from this.
I will.
Al Latimer, go ahead.
Hi, Len. I guess you ended up forgetting about me before.
Oh, sorry.
Well, we were talking about Pluvicto, and you told me to go ahead with Giftana, but we weren't finished with Pluvicto. It's okay.
Right. I'm sorry. Go ahead.
Okay, so I started Giftana sometime last fall. I've had 4 treatments now. The first one I had a dramatic decrease. Second one I had a small decrease, and then it's been kind of flat. The third one was kind of flat. Now it's gone up a little bit because the doctor says because I went 5 weeks instead of 3 weeks between treatments. So now I'm going to have another one 2 weeks from now. So here's the thing, Doctor Doctor in California. Somehow I just lost his name.
Schultz.
Dr. Schultz. Sorry, Dr. Schultz. He wants me to add carboplatin to the Giftana now, and not wait for the Giftana to fail. He says the two drugs together work better than the one by itself. Now, Dr. Belusic here says, well, I don't want to shoot all my bullets at once. I want to save the carboplatin for maybe later when we need something else. So for now, I'm continuing with the Giftana alone. I guess we'll see what the PSA comes back. I have another treatment at the end of next week. See where it goes. But Schultz was very adamant about saving a drug is ridiculous. So I was wondering if anybody has been on Giftana, if anybody's done both of them, has done either one of them. Anybody know anything about what's going on in the out in the world on this? There doesn't seem to be too much literature on it. So anyway, that's my question.
Anybody want to tackle that one? We have had guys who have been on docetaxel and carboplatin, and maybe Giftana and carboplatin. I know that. They seem to tolerate it no worse than, docetaxel. So, and I believe it is more effective, and they usually prescribe it for the more aggressive treatment-resistant cancers. So it's probably a good idea. I don't know if anybody else has a different opinion.
I think it's pretty common in other cancers to do that.
Yeah.
Yeah, yes, it is. Well, if I was living in California and I was near Dr. Schultz, I would be following what he would like, but I'm not there, and Belusic has pushed back against me on this so far. So I'm willing to go along with what he thinks is best for the time being. Anyway, we'll see.
Did Belusic give you a reason why he didn't want you to add carboplatin?
Well, he said if we were going for a cure, I would definitely be throwing the book at it, so to speak. But since we're not going for a cure, we just want to try to drag things out as long as possible. I don't want to use both of them now. And that was basically what he said.
Right. So I guess he's looking more at the quality of life angle.
And of course, quality of life figures into it as well. But his philosophy for kicking the can down the road, so to speak, it was different than if he wanted to aggressively go for a cure. And obviously, I'm way past a cure.
There was an article, I can't remember where, about the time toxicity of cancer therapy. And in some cases, a chemotherapy regimen may extend your life, say 9 months, but you go through 6 months of hell. So you really get about 3 extra months of lower quality of life. So that's an individual decision people have to make.
Well, right now on the Giftana alone, life is not really hell. I mean, I have some fatigue from it and some dry mouth, but I've heard what hell is like, and I'm not in hell yet.
No, I meant the combination of chemo drugs. And Giftana is one of the more gentle chemotherapy drugs, much easier.
So yes, so it was more gentle than the taxane, Taxotere.
Yeah.
What is your actual PSA right now, Al?
About 125.
And it got all the way down to, wasn't it? I'm just pulling it up, 60 something.
No, not this time around. Let me look it up. I don't. I think it was around 115 was the low point.
115. Yep, I have 115, and now you're back up to, what did you say, 145?
Well, let me look here. Um, okay, so the actual low point was 106.
Okay.
And now after, well, okay, so the next one was basically flat, and then now the one I had a week ago was 170. So it jumped up quite a bit, but Belusic wasn't concerned about that because I waited 5 weeks for a treatment rather than the normal 3. So
Yeah. And again, I just don't think we should be, especially with people who have weird PSA like you or like Kang. Kang's is low and very low, and there's something going on. Yours has always been astronomically high, but it may not reflect the condition of your disease. And you're the sort of people that, rather than doing these PSAs, you should be monitoring with scans, is what
well,
I would.
that's what Belusic wants to do.
Right.
But I've had a bunch of PSMA PETs since they first came into existence, and every single one of them reflected very precisely my PSA level. My PSA level was up, the scan was worse. My PSA level was down, the scan was better. As a matter of fact, my PSA got down to 1 on the Pluvicto. My scans cleared up completely. But of course, there was still the disease there; it just wasn't detectable anymore. Um, but I may produce a lot of PSA, but I still think it's fairly reflective of what's going on. So, but anyway, I think this next 2 weeks from now, well, 2 weeks from last Friday, I'll be having another PSA test, and I mean, if that's going up again, then obviously that's different than if it's dropping back down again.
So, I want to go back years and years to the early 2000 and teens, the late 2000s. And back then it was Snuffy and Schultz, as you know, who were always doubling up on the drugs. And the centers of excellence were always sequential. Today, I guess we've come closer to their thinking years ago when it comes to hormonal treatments, where we do double up. I mean, we don't wait now until ADT stops working to add ARSI. As far as giving 2 chemo agents at once, it has to be the oncologist's call. There are a lot of docs who will give 2 agents at once. If we think that your disease is morphing and there's an element of neuroendocrine in it, then yeah, they'll give you the carboplatin at the same time as the ADT. And one of the things that you might want to be talking to Belusic about is doing some of these tests that are coming available to see if we can see anything neuroendocrine, getting a biopsy to see if we can see any small cell disease in there.
Well, I had a biopsy when I was doing that clinical trial, and there was no indication of that.
And how long ago was that?
That was July of last year.
So that's like 9 months ago at this point in time.
That would be
8 months ago.
That would be correct, yes.
So, again, but that's the discussion I would have with Belusic about, do you want you want to hold off on the carboplatin? I would be saying, well, can we be looking? What else can we use to see if there are signs of neuroendocrine disease? Again, remind us all, Len, because I know I always forget. What are the markers that somatostatin? Isn't that one of them?
Oh, somatostatin. Well, that's more for the GI neuroendocrine. I think Dr. Jack, I think he knows them better than I do. Of course, DLL is the most common marker,
Yeah,
76%.
but
DLL.
but there's no commercial DLL test right now.
I don't know. Is Jack still with us?
Yeah. Yeah, why would I know about it other than the fact I read about it in ASCO? Why would I know any more than you?
Well, I thought maybe you remembered better than me.
No. I've been reading the ASCO literature. I attended the meetings virtually.
Synaptophysin was another one.
Those, you mean the markers?
Markers, yeah.
Yes.
Oh, I didn't realize you. Yeah, right. Synaptophysin and chromogranin A.
Yeah.
And yeah, those.
Chromogranin A was the one I was trying to remember, and
Right, yeah.
somatostatin.
Yeah, they've been trying to find those from the get-go with me. The guy up there, I don't talk about. He was always searching for neuroendocrine, scaring the daylights out of me. But yeah.
I think you could have that discussion with him, Al. I mean, say to him, should we also be looking? You don't want to use the carboplatin. I mean, I know why. I shouldn't say I know why. I mean, there's good reason to understand why Schultz wants to add the carboplatin now, because he wants to head off the neuroendocrine at the pass. He thinks there may be some small cell. What I'm saying is, rather than suspect that there could be some small cell, why don't we look for it, and why don't we go after the tests where you might express something in the way of small cell disease?
Well, is the carboplatin specifically to target small cell? Or
Not
does,
specifically, but it's one of the main. A platinum-based drug is what they would go to right away if they felt that you had an inkling of small cell disease. And I suspect that's what Schultz is saying. Well, I don't know what's going on, but my response to Schultz is, but this is how it's been from the get-go, Dr. Schultz. It's been up, it's been down, it's been up and it's been down. Why would we throwing everything at it without having any evidence? That would be my question to Schultz. Why do you think the platinum's going to make a difference if this guy has hormonal? Where are you coming from? And he's going to faff around because he just likes to throw spaghetti at the wall. That's his style, and see what sticks. Whereas if you talk to Belusic, he's going to be more reasoned and say to you, well, yeah, maybe we could look for this or we could look for that. I mean, that's the way I would see it handled.
well, if I had no evidence of small cell disease last July, it could have changed between then and now, I suppose.
Yes, it could have done. And it comes on very quickly. And if we don't catch it in the early days, DOA, literally. So it's really important to catch this small cell, catch this morphing as early as we can. We don't have a large window to treat it.
Okay, well, I will definitely bring that up to him. And I will say he's not against using the carboplatin. He just wants to be more reasoned than when he uses it.
Well, I mean, I think he probably is taking the approach of do no harm and quality of life, and it's very reasonable to do that, particularly with with your disease. But you've always been pretty unusual. You've always made huge amounts of PSA and yet lived a relatively decent life. So I think that yes, there's you're not the average dude in treating this.
By the way, come December of 2025, it'll be 30 years since I had a radical prostatectomy.
Unbelievable,
30
unbelievable,
years. Isn't that crazy?
unbelievable. But I think it's reasonable to look for it now. I think that what Schultz is doing is probably treating you without having proof that it's there. What I'm suggesting is talk to one of your docs and maybe we can find some evidence. And if we can't find some evidence, it's all the more reason not to use it right now and to wait.
Okay, all right. Well, that's a good idea. And Schultz, I think Schultz is just your former theory that he's throwing something again. He's throwing things against the wall. I mean, that's what he's doing. He has no specific evidence. He just thinks two works better than one, and we should do it now.
But he's always thought that. As
I
long
know.
as I've known that Schultz, when people used to drop Snuffy and go to Schultz, he was doing the same thing that Snuffy was doing. That was the Snuffy approach.
I'm more than familiar with that. I was a Snuffy guy for 10 years.
Well, there you go. And Len's put the markers in there, and Len's absolutely right. The DLL3 is a great marker, but we still don't have a commercial DLL3 test. The only way to get tested for DLL3 is to go into a trial. And then, if you've got evidence that would be attractive for a trial where they'll give you a DLL3 test, you can get it.
I'm copying that information.
You can download. You don't need to copy. Just download. Go to those three buttons at the top and go to download, and then the whole chat will be there for you.
Okay.
See those three vertical buttons?
I got it. Yep, I see it.
Okay. And it'll be in your either downloads or documents. I think it's in your documents file.
No, it's not in the three dots.
Yeah, I don't see it there either, Rick.
Well, my three dots says download chat messages. The three vertical dots next to the pin on the same line as chat. See where it says chat?
Yeah.
Oh, the vertical ones. I see them now, yes.
Three vertical dots.
Oh, yes. I got it. Yep.
Right. Okay.
Yeah, so it ends up in my downloads.
So I am going to go out on a limb here, Al, and say, after hearing your 30 years survival, you're indestructible, man. Don't worry about it.
I was thinking the same thing. You're my hero, Al.
I thought that was true for the first 20 when testosterone suppression alone was working, but these last 10 have been much more of a struggle.
How old are you, Al?
76. I'm still a baby.
Yeah. So you were only 46 when you were diagnosed, if
That
my
is
memory-
correct. 46. 46 with a, the PSA was 19, the Gleason was 5 + 4.
Oh,
That was a Dr. Epstein. Dr. Epstein was doing biopsies way back then.
Yeah.
Last century.
Which Dr. Epstein?
Jonathan Epstein, the one at Johns Hopkins.
Really?
The guy. That's where I had surgery, was at Johns Hopkins.
So he was a clinician, not just a pathologist.
He was
No. He read the pathology is what
he was the go-to guy then. I had it done locally, and then I sent it to Dr. Epstein to do a second opinion. 1995.
Yeah, I think he's 66 or 67, Epstein.
But he was already the go-to guy then.
Yeah.
So he was working with Walsh or Ballantyne Carter. Who was he working with?
Well, he was working for all of them, but Ballantyne Carter did my surgery. Walsh was too busy. But yeah, I mean, the plumbing part worked fine. The nerve sparing, and haven't had any problem with that, at least not until I started Lupron. But it was already in my lymph nodes, so I was, it didn't work. We knew it right away. So anyway, yeah, 30, it'll be 30 years in December.
You're kind of like the Forrest Gump of prostate cancer. You're going through historical changes.
So, well, back then, Johns Hopkins, my PSA started going up. Johns Hopkins said, "Well, we're not worried about your PSA going up. We're not going to treat it until we have positive scans." And my PSA kept going up and up and up, and my scans kept staying negative. So well, when my PSA got to 200, I got really nervous and decided to change doctors. So, and then I started Lupron. That was in 1997.
Yeah, you hear that, Kang?
Yes, yes. We love you, Al.
Is that when you went to California?
Pardon?
Is that when you went to California from Hopkins?
No, I went to MD Anderson at that point in time.
MD Anderson.
So I was there for a while, and I got tired of the institutional approach, and that's when I discovered Dr. Myers, and I switched to him. And well, his thing was, first thing he always says to you is, "I play the ball as it lies. I'm looking at your disease, and I'm going to figure out the best way to tackle it."
Yes, sir.
Was he refusing to take insurance even way back then, Al?
No insurance. It was, I don't know. I think originally it was like, I don't know, it was like $1,000 a visit. But you got a whole hour with him. He didn't come in and talk to you for 5 seconds.
Yeah.
You had a lot of time to talk to him. That was, so I don't know. I would have at that point, I would have paid anything for it, really. But yeah, it was $1,000 totally out of pocket. Didn't take any insurance. Never did. He had a nice little clinic outside of Charlottesville. Very, very cute little place. I like Charlottesville. I like Virginia.
He used to give these great little video chats periodically. They're very helpful.
Yes, sir.
Oh, he had a background at NCI or NIH or something. He was the
director of pharmacology with
drug interactions
with the FDA.
Yeah, so he tried a whole bunch of different things off label with me. Try to get my PSA to less than 0.01, and he never quite did it. 0.02 I got to, but never all the way less than 0.01. Anyway, long time ago. That was starting in 2006.
You ever been written up and presented at grand rounds?
No.
You should be.
Yeah.
Well, that's only part of my story. I've had 3 other cancers too.
Oh my gosh. What are those 3?
Well, the worst one was Merkel cell.
Oh no.
Wow.
I had Merkel cell carcinoma 12 years ago, and that was another medical adventure. I went to Seattle, spent a summer there being treated for it, and it hasn't shown its ugly head since.
Dr. Nyhan?
Dr. Neum, yep.
Neum. Oh, he's the best in the world.
Yeah, great guy, great doc to work with.
Yeah, well, I'd never bet against you, Al, that's for sure.
Oh, sure.
All right,
Oh,
Bill.
talk about a tough disease, Merkel. Oof,
Yeah,
friend of mine.
Merkel cell is usually pretty quickly fatal, isn't it, guys?
Gotta
Doctors?
catch it very early.
So, I had a type of Merkel cell. The first thing they wanted to do was they wanted to find the lesion. I had no Merkel cell lesion anywhere. So they weren't sure why, but they know that patients that show up with um, no presentation, no visible presentation on their skin of Merkel cell do better. Mine showed up in a lymph node in my I don't know if you can see it right there, right above my elbow. It was in a lymph node there. My elbow started swelling up, and the doctor sent me to an orthopedist. He thought I had tennis elbow or something. I don't know. On and on and on. Finally biopsied it, and lo and behold, it was Merkel cell. Crazy. That was in 2012, so that was more than 10 years ago now. And they have a blood test that I send blood to them every year. They have a blood test that can early detect a reoccurrence. And so far, so good.
I think once you get past 5 years, you're clean.
Yeah. Well, that's what my brother-in-law thought. He had ocular melanoma. 17 years later, it showed up again everywhere.
Oh my God.
Anyway, what else you want to know?
What were the other two?
Extra. Okay, so this one is an interesting one. Extra mammary Paget's disease.
What is it?
Extra mammary
Extramammary
Paget's
Paget's.
disease. It's a cancer that shows up in the genitalia of men and women. It was in my crotch, and so now I had another medical adventure. I went to MD. I went to Mayo Clinic in Rochester, Minnesota. There was a guy there, Dr. Otley, that had kind of a subspecialty unit, and he took care of that. I haven't seen that again either. But interestingly, it's a very rare cancer. Last year, my brother was diagnosed with it, and he also has prostate cancer. So Dr. Myers always thought there was a connection between prostate cancer and extramammary disease because I was still his patient when it was diagnosed. But anyway, but now I'm rethinking that since my brother had it. And if any of you guys have an itch down there that won't go away, you need to have it biopsied because you never know.
Where's Jimmy? Where's Jimmy when we need him?
We need music.
I had an itch that kept coming and going, and the doc thought it was chafing from I was at the time I was doing a lot of road biking, and he thought it was just chafing. But so it'd go away, come back, go away, come back, and finally, I think it was Dr. Meyer said you need to have that biopsy. Anyway.
Well, don't stop now. I mean, just what's the fourth one?
Well, the fourth one was I had some skin cancer on my nose.
Ah, kid stuff. The other stuff is horrendous.
Oh boy. Oh boy.
Did you ever have a patient like that, Jeff, John?
Iron Man.
Yeah.
Iron Man.
I have no explanation. But one thing is to go to the right docs. I mean, Dr. Neum was great. Dr. Otley and Mayo was great. Just haven't found the greatest one yet for the prostate cancer. It just won't go away.
And I assume you've had genetic testing. You never came up with anything.
No, I've had those tests multiple times.
When was the last time you got sequenced, Al?
last year. Last year, well, that's how I ended up. That's how I ended up in that clinical trial. That
Yeah, that's
they were
right. I mean,
targeting the SPOP mutation.
right. And I would,
That
you
was
know,
that
it
was
would,
last spring. I had the last time I was sequenced.
so I would get sequenced yearly if it were me with your type of disease, just to see what, you know, it's just unstable. What was your microsatellite? Were you at reading your MSI reading?
Um,
Was it high or
no,
not?
it was not high.
It wasn't high. Well, I would look. Belusic is great. But if you needed a second opinion, to me, I would probably go to somebody like Dr. E because she thinks outside the box and she's super smart and she may have an idea on what's going on. Um, you know, she's also, she's an academic. But I think that Belusic is great. But I'm just saying, if you wanted another take and somebody to look at it unconventionally, I think she would be a good person to consider.
Well, I did see her last spring. She was the one
Oh,
that did the genetic testing, and she was pushing doing some Keytruda at the time. But I ended up doing the clinical trial instead, and haven't pursued anything
yeah.
else with
Well,
her.
I don't want to say I wouldn't consider my mind on the same level as hers, but that's why I was asking you about the MSI because your disease is just so scattered, and maybe she's right. Maybe she has that same hunch that I have that maybe you would respond to.
Well, it's not off the table, I suppose. I still on the back burner.
Well, you could have Belusic have chat with her. Have Belusic have a chat with her.
Yeah, well, back when I was talking about Keytruda, somehow that never happened. Um, well, for the time being, I'm going to pursue the Jeff here, and we'll see what happens.
Okay. Well,
But the idea of the small cell disease, certainly need to keep an eye on that. Certainly a good idea.
All right,
all
Al, thanks so
right.
much for sharing. That's quite a story, quite an inspiration.
Okay, those were the highlights.
We need a
Yeah, I mean,
special 2-hour session for you for your lowlights.
that's right. I mean, I'm just glad that we had a day today that was so light that we could talk to you about this, and because it's fascinating to listen to you. You know.
Well, my pleasure. So anyway, there's hope out there. I mean, prostate cancer takes a long time to get you, or it can anyway.
Yeah.
That's
You
right.
know, when I was in medical training, you were known as a fascinoma. That was
Is the
that was
word
the term, a fascinoma, fascinating.
Fascinoma.
But like all doctors would say, oh my God, amazing.
One last thing. One of the things that Dr. Myers did was he took me off the Lupron and put me on estrogen patches, and that made a big difference in my life. That that was much easier to tolerate. My bone density actually got better once I started the estrogen patches.
Are you still on that?
I'm still on it, yes.
Yeah, just read an
Here,
article
here.
on that.
How'd you like that, Larry Schuler? We're not talking a couple of years. We're talking about what, 15 years? Al, how many years?
On ADT
17? No,
since
on estradiol.
2006.
There you go. 2006.
Well,
18
Richard, what,
years.
what,
19
what's already
years,
been on for
Larry.
22?
What did you do about the gynecomastia, Al? What did you do?
I had a double mastectomy eventually. or actually it's called top surgery. I went to a doc that specialized, it had a subspecialty in women that were transitioning to be men, and so he was lopping off breasts, I don't know, a dozen a week.
Oh boy.
So
Larry,
I have a nice
Larry,
flat
what did
chest
you
now.
just say, Larry? How many years? You know, somebody was on it for 22, not you, right?
Richard Wassersug.
Oh, yeah. Okay, yes. That we know.
Yeah.
That we know.
He also had a double mastectomy or whatever they call it.
Yeah. But
Yeah,
his
just putting up
disease,
with mine.
yeah, but you know the difference with Wassersug is that his disease has been very manageable, unlike Al's.
Right.
Well, the estrogen worked well for me from 2006 to 2015, 16, somewhere. Like I was another 10 years on that. Oh, actually, it's estrogen plus Avidar. He has me on. I'm on two things, um, but eventually my PSA started ticking up little bit by little bit.
All right. Okay, guys, I think I need to close up because I want to unpack and put some groceries away that I bought on the way home.
Hey, do you want me to stop the recording or you'll do that?
We can stop the recording. Yes, I think we